You can start.
Yeah, sir. Good morning, everyone. From today, we are going to discuss about the trauma series. And my topic is the initial assessment of a trauma patient, and that is in ICU. So my name is Dr. K. Harini, and the moderator is Chandresh. Coming to the trauma has been the leading health problems over the world and most common being cause of mortality and morbidity. The initial approach to trauma care is a process that consists of an initial primary assessment, and you rapidly resuscitate a patient, and you go for a detailed secondary survey followed by a diagnostic test, and ultimately the patient disposition. The subsequent mortality and morbidity of a patient are connected to the initial assessment and resuscitation. So if your initial assessment and the resuscitation is very nice, there will be less mortality and morbidity. And coming to the approach, how do we approach a patient of trauma is a preparation. So our hospital or the ER should be prepared to handle a trauma case and a triage. And then comes the primary survey with immediate resuscitation of patients with life-threatening injuries. And they'll be having an adjuvants to the primary survey and resuscitation, considering the need of transfer of the patient. And the secondary survey, which includes head-to-toe examination and a detailed patient history. And we have an adjuvants to secondary survey and continued post-resuscitation monitoring and re-evaluation. And finally, the definitive care. So what is triage? Triage is nothing but the sorting of our patients based on the resources required for treatment and the resources that are actually available in the hospital. The order of treatment is based on the airway, breathing, and circulation priorities. Airway includes with cervical spine protection, breathing, and circulation with hemorrhage control. The other factors also which affect the triage are the severity of injury and the ability of survival. So we have multiple casualties and the mass casualties. What is the difference between these two is that in the multiple casualties, the number of the patients and the severity of their injuries do not exceed the capacity of the facilitating center. In such cases, the patients with life-threatening problems and with multiple system injuries are treated first. Coming to mass casualties, it is the number of patients and the severity of injuries that exceed the capacity of the facility and the staff. In such cases, patients have the greatest chances of survival and requiring the least expenditure of the time, equipment, and supplies, and the personnel are treated first. And coming to the emergency department triage and acuity scale, it has 5 levels: the resuscitation phase, the emergent phase, the urgent, the less urgent, and the non-urgent. We categorize the patients depending upon their condition and the severity of injury into one of these levels. And coming to the trauma scoring systems, do we need to really score our trauma? Yes, definitely. Because depending upon the trauma scoring systems, we assess the severity of the injury and the modality of the treatments as well. It has an anatomic scoring system, physiological scoring system, and the combined scoring systems. In anatomical scoring systems, we have an abbreviated injury scale, the injury severity scale, and the new injury severity scale. Whereas in physiological, we have the trauma score, the revised trauma score, and the Apache. In the combined, we have the TRIS, that is the trauma and injury severity score. And this is the revised trauma score. We have a mnemonic like RTS, the respiratory rate, TI&C the BP, and S stands for Glasgow Coma Scale. And in the TRIS, that is the trauma injury severity score, it includes revised trauma score, injury severity score, and the age and the mechanism of injury. Can we really remember this? Yes, but we have a much more sophisticated scores as well. Coming to the abbreviated injury score, in this, the head, neck, and C-spine are considered to be a minor injuries, whereas any face, including nose, mouth, eyes, and ears, come under the moderate, whereas the thoracic and the thoracic spine with the diaphragm come under the serious injuries. Abdominal and lumbar spine comes under the severe injuries. And the extremities, including pelvis, comes under critical, and the external soft tissue injuries come under the maximal, which is currently untreatable. So how you calculate the injury severity score is, we calculate the abbreviated injury score. We We multiply it by top square by 3 and we add upon all the values. Coming to the primary survey with the simultaneous resuscitation. Primary survey is nothing but the process of how we evaluate the patient, which we should not take much more time for evaluation. The primary survey encompasses the ABCDE of the trauma care and identifies the life-threatening conditions by adhering to the sequence. What will be the sequences? A, airway maintenance with restriction of cervical spine movement, which is much important, breathing and ventilation, circulation with hemorrhage control, disability, that is the assessment of the neurological status, and the exposure or environmental control. This is the normal sequence which we follow, but when there is a catastrophic hemorrhage, the circulation will be in hand with the airway maintenance and restriction of cervical spine movement. And how long you should take for assessing a patient? It should be done within less than 10 seconds by identifying the patient, asking his her or name and asking what has happened. An appropriate response suggests that when you ask a patient if he is able to speak, then there is no major airway compromise immediately, and able to generate air movement and permit speech. The breathing is not severely compromised, and when he is able to tell you what has actually happened, the level of consciousness is not markedly decreased. You should be reassessing it frequently to see if there is any compromise in any of these. Coming to the airway maintenance with cervical spine stabilization. Initial evaluation of a trauma patient, the first thing you should assess is for the airway patency. What do you really look for in an airway? We should see any obstructions, in which includes a foreign body, identifying facial, mandibular, and the tracheal and the laryngeal injuries. When there is a signs of airway obstruction, we should be clearing the accumulated blood by suction or secretions that might cause the airway obstruction. These measures should be done while restricting the cervical spine motion. If a patient is able to communicate verbally, then less likely the airway is jeopardized. And a GCS of less than or equal to 8, we need a definitive airway placement, that is with a cuffed ET tube. And what is the jaw thrust and the chin lift maneuvers? So if a patient is unconscious and there is no gag reflex, you need to, until you intubate, you need to secure an oropharyngeal airway. And what comes as a jaw thrust and chin lift is, jaw thrust, it is an alternative to head tilt or chin lift maneuver. Whenever we are suspecting a strong, whenever we are having a strong suspicion of the cervical spine injury, we need to do this jaw thrust. How we do is, place fingers posterior to the mandible and apply upward and forward pressure. During this procedure, we should minimize the cervical spine movement. And coming to chin lift, this is likely to compromise your cervical spine stabilization. This is usually done when your jaw thrust is being difficult to ventilate a patient. And moreover, the death from a hypoxic airway obstruction is much more than the quadriplegia resulting from the emergency airway manipulation. So when it comes to saving a life of a patient, you can go with the chin lift. So while assessing and managing a patient airway, we have already discussed that immobilize the spine, and a normal neurological examination does not exclude a diagnosis of a cervical spine injury. So until proven otherwise, your cervical spine should be protected with a cervical collar. And this is how we do a manual inline stabilization. We need to immobilize the head by either your arms, or you can put a sandbags or a saline bags on either side of a patient's head. And we can use a cervical collar as well. And when to intubate the patient, you can remove the cervical collar with immobilizing the spine. And coming to the breathing and ventilation, your airway patency alone does not ensure that the patient is adequately ventilated. So adequate gas exchange requires maximum oxygenation of the tissues and the carbon dioxide elimination. So for a proper ventilation, what we need is the proper lung functioning, chest wall, diaphragm. So each and every component should be rapidly examined and evaluated. So what all we look for in a NEXUS, we see for the jugular venous distension, the position of the trachea and the chest wall movements, and perform auscultation. This is very difficult to do in a busy emergency department like auscultation and percussion. But what can we do is a visual inspection and palpation of the entire chest. So what do you look for? What are the injuries that significantly impair ventilation are the tension pneumothorax and the massive hemothorax and the open pneumothorax and the tracheobronchial injuries. In these, the patient will not give you a significant amount of time and these should be reacted very fast. How you see for a flail chest is in a patient normally, when we inspire, your ribcage moves inside and we expire, it moves outside. But the difference, there will be reverse happening to cause it a lung injury. And because a tension pneumothorax compromises ventilation and circulation rapidly, chest decompression should be done immediately. And whenever an injured patient is there who is maintaining their airway borderline, definitely for everyone, you should put a supplemental oxygen mask because to achieve the optimal oxygenation. And a pulse oximetry is needed to see the adequacy of hemoglobin saturation. Whenever you are having a simple pneumothorax, prefer to place an ICD before positively ventilating a patient because the positive pressure ventilation will convert the simple pneumothorax into tension pneumothorax. And coming to the circulation and the hemorrhage control, this is a very important thing wherein the circulatory compromise can be resulted from a variety of injuries like your deficit blood volumes, your cardiac output, and the bleeding. So we have a trauma lethal triad in which it includes acidosis, coagulopathy, and hypothermia, all of which is very important. And this decides your mortality and morbidity of a patient. Coming to the blood volume and cardiac output, hemorrhage is a predominant cause of preventable deaths after an injury. So whenever your patient is having a hypotension, after ruling out a tension pneumothorax, you should see for the other bleeding sources. And the rapid and accurate assessment of an injured patient hemodynamics is very essential. How do you assess for the normal blood volume of a patient? You see for the level of consciousness. When a patient is able to communicate with you, there is less likely that the cerebral perfusion is impaired. And coming to your skin perfusion, when your ashen or pale extremities include your patient is hypovolemic, whenever there is a pink extremities, maybe the perfusion is normal. And a rapid thready pulse is typical sign of hypovolemia. And how do you assess for a pulse? Either you go for a central pulse like a femoral or carotid, and you have to check it bilaterally for quality return or regularity. Absent pulses cannot be attributed to local factors, signify the need for the immediate resuscitatory actions. Coming to the control of the bleeding, bleeding may be external or the internal. The external hemorrhages is identified and controlled by primary survey by direct manual pressure on the wound. Or else we can even go for the tourniquets when there is excessive bleeding from the extremity. But you consider tourniquet only if the manual pressure is failing to control the bleeding. And when applying a tourniquet, you should be aware of the ischemic injuries. And blind clamping is not advised as it can result in the damage of the nerves and the veins. And coming to the internal hemorrhages, the major sources can be a chest, abdomen, retroperitoneum, pelvis, and the long bones. So the source of bleeding, how you usually identify is for a chest X-ray or a pelvic X-ray. The most bedside tool which helps us is the FAST, that is ultrasound machine, the focus assessment with sonography for trauma, and a diagnostic peritoneal lavage, which we'll be discussing in later. And a definitive bleeding source along with what we should use is appropriate replacement of the intravascular volume should be done. And you need to have a 2 peripheral large bore venous catheters, mostly of 14 to 16 gauge, for administering the fluid, blood, and plasma. The blood samples for the baseline hematological studies should be taken. And a pregnancy test should be done for all the female patients of the childbearing age. And we need to get a blood type and cross matching. You need to have a baseline ABG to assess the degree of shock and the blood gases or the lactate levels. When peripheral venous catheterization is impossible, you can go for an intraosseous infusion or the central venous access or a venesection. Venesection needs expertise, so which is not usually done in emergencies. And an aggressive and controlled volume resuscitation is not a substitute for definitive control of hemorrhage, because mostly the injury will be of the hypovolemic, and the IV fluids which we give should be warmed to the warm environment, that is a temperature of 37 to 40 degrees, or administered to the fluid warming devices. Why you should not give a normal fluids is for prevention of the lethal triad. A bolus of 1 liter of isotonic solution may be required to see for the patient's initial response. And coming to that, we should not aggressively resuscitate a patient just by giving fluids before the control of bleeding, which can be detrimental. So now we have our two topics, like we will be discussing about the damage control resuscitation and the permissive hypotension. And the severely injured patients are at risk of coagulopathy, which is aggravated by our resuscitatory measures. So massive blood transfusion protocols should be initiated when there is an ongoing bleed. And do we have a role of tranexamic acid? Yes, definitely. There are some studies, the CRASH 2 trial and all, which show whenever one tranexamic acid is given early, that is 1 gram delivered within 15 minutes of injury, and then 1 gram over 4 hours, and within the 3 hours of injury, has reduced the risk of mortality. Coming to damage control resuscitation, what exactly is damage control resuscitation is the early blood product administration and hemorrhage control with restoration of the blood volume and physical stability. So what all will be coming is a permissive hypotension and the restrictive fluid administration, the hemostatic resuscitation, the rewarming and correction of any acidosis, and the arrest of hemorrhage by surgical or non-surgical techniques. With whom we should go for a damage control resuscitation is, we have a parameters based on the anatomical, physiological, and the lab parameters. In anatomical, when the injury severity score of more than 36, or an penetrating abdominal injuries, or a pelvic or long bone fractures, we should be choosing for the damage control resuscitation. And the physiological parameters, when your systolic blood pressure is less than 100 and your heart rates are more than 100, when your urine output is less than 50, with the lab parameters of lactates more than 2.5 and INR more than 1.5 with base deficit less than 6, yes, definitely you should go for a damage control resuscitation. And coming to the permissive hypotension, it is also known as a hypovolemic resuscitation. It is used to describe a process that minimizes the fluid administration until the hemorrhage control. So current evidence suggests that a moderate hypotension for less than 30 minutes can be tolerated by a trauma patient without progressing to an end organ failure. Do we go for permissive hypotension in all the patients? Definitely no. There are certain contraindications for the permissive hypotension. Those are a traumatic brain injury patient and the pregnant females, and a stage 3 and stage 4 grading of your hypovolemic shock. And the pre-existing conditions like an hypertensives and your angina, your coronary diseases, your carotid stenosis, and a severe cardiovascular dysfunction. And the European guidelines on the management of major bleeding and coagulopathy, they have found that there are 39 recommendations, out of which what they have told mainly about is a restricted volume replacement strategy and a goal-directed strategy, which is much more useful. And what all the other suggestions by European guidelines are a tourniquet use, which we have already described. The ventilation, hypoxemia should be avoided and normoventilation should be given. Hyperventilation may be applied in the presence of a cerebral herniation. And the tissue oxygenation, which we usually go on the targets of the systolic blood pressures. And what is the type of fluid which we usually go for is an isotonic fluid. And if your INR is and a plasma-based coagulation strategy, including FFPs, should be administered to maintain a PT and IPTT of less than 1.5. Plasma transfusion should be avoided in patients without any bleeding. Does desmopressin have a role? It may be administered in patients treated with platelet inhibiting drugs or a van Willebrand disease, but it is not routinely used in a bleeding trauma patient. And coming to other like a recombinant activated coagulation factor and the thromboprophylaxis. Thromboprophylaxis should be employed within 24 hours after bleeding has been controlled. Early mechanical thromboprophylaxis with intermittent pneumatic compression should be used. And what is a trauma-induced coagulopathy? There are studies on it, which was published in the year 2016. Following severe injury and bleeding, 20 to 40% of the patients will have a trauma-induced coagulopathy, which is associated with increased mortality. So what are the characteristics of a trauma-induced coagulopathy is hypofibrinogemia and hyperfibrinolysis. As understanding the mechanism, the use of blood and blood products and procoagulants have evolved to target the key drivers of the TIC. And these are the various blood products which we come across. Coming to the red cells, we usually give it when they're in the massive transfusion protocol. For FFPs, the proper trial, which is a randomized control trial, which is done against 1:1:1 of your plasma, platelets, and red cells in trauma versus 1:1:2. And the early survival benefit is observed. And the greater the likelihood of hemostasis is achieved with the 1:1:1 group compared to the 1:1:2 group. And coming to the disability and the neurological evaluation part, a rapid neurological evaluation establishes the patient level of consciousness, the pupillary size and the reaction, in identifying the presence of lateralization signs and determining the spinal cord injury if it is present. So what is a quick access is a GCS. So we have GCS and a 4 score. The GCS score is what we regularly follow. In this, we see for the eye response, verbal response, and the motor response. The best score includes 15, and a comatized patient is less than or equal to 8, and unresponsive is a score of 3. Coming to 4 score, in this we have eye response, motor response, and the respiration and the brainstem reflexes are also to be considered in the 4 score. A decrease in patient level of consciousness may indicate there is a cerebral hypoperfusion or an issue with the cerebral oxygenation. This may be because of the direct cerebral injury or the secondary traumatic brain injury. So any sudden altered level of consciousness needs to be immediately re-evaluated for oxygenation, ventilation, and perfusion status, hypoglycemia, any narcotics or other drugs. So we should repeatedly check for the patient's level of consciousness. A primary injury results from the structural effect of the injury to the brain, whereas the secondary injuries mainly depends on maintaining the oxygenation and perfusion. And coming to exposure or environmental control, this is a very important thing. And during the primary survey, we should completely undress a patient for a thorough examination and assessment. After completely examining a patient, we need to cover the patient with a warm blanket or an external warming device to prevent the hypothermia, which is one of a part of a lethal triad. And warm IV fluids to 39 degrees before infusing them and to maintain a warm environment is needed. And after coming to the airway, breathing, circulation, disability, and exposure, what are the adjuvants you have for your primary survey? That is, in hand, you need to have a CO2 monitoring, the pulse oxy, ECG, your ABG, and a urinary and gastric catheters to be used to assess for the urine outputs and hematuria, and gastric catheters for stomach decompression, and X-ray like chest and pelvis, ultrasound, and the diagnostic peritoneal lavage. And you should be assessing on your physiological parameters like the pulse rate, blood pressure, ventilator rate, ABG levels, and the temperature with urine output. These all reflect the adequacy of your resuscitation. And coming to secondary survey, usually secondary survey doesn't begin until you complete your primary survey and the resuscitative efforts are underway and improvement in the patient vital functions. The other person, one person can do his primary survey, and if you have a helping hand, the other person can also go with the secondary survey. What do you do in a secondary survey is a head-to-toe evaluation of a trauma patient. Usually we say it is a head-to-toe, front to back, and surface to core. And a complete history and physical examination, including reassessment of all the vital signs, is required. And in a history, we have a mnemonic like AMPLE, which is you should know what are the drugs or medication the patient is allergic to, the medications currently used, whether he is on any anticoagulations or antiplatelets, in the past illness or the pregnancy status, when did he have his last meal, and the events or environment related to the injury. With this, we'll know the severity of an injury, whether it is a mild injury or a severe traumatic injury. And coming to examination in head, we assess all the neurological injuries. We see for the pupillary size and hemorrhagic contusions of the conjunctiva, or any penetrating injuries or any contact lenses if your patient is having. You should make sure that it should be removed, because after trauma, there is high chances of having an edema and any dislocation of the lens or an ocular entrapment. Any of the visual acuity deficit should be documented properly. And coming to the maxillofacial injuries, you should palpate all the bony structures and assessment of the occlusion and intraoral examination as well. Maxillofacial trauma that is not associated with airway obstruction or major bleeding should be treated only after the patient is stabilized or the life-threatening injuries have been managed. We have a Kruger's classification and Lee-Ford's classification for a maxillary and mandibular fractures. We need to know this because whenever there's a mandible fracture involving the angle or the coronoid process, it becomes difficult for ventilating a patient, even for our laryngoscopy as well. So with these terms, we need to be prepared for your emergency crash intubation or a difficult airway cart. Whenever there's a nasal bone fracture or a nasal sinusitis, you should be careful when you are placing a Riles tube. Definitely with a nasal bone fracture and a base of skull fracture, avoid placing a nasogastric tube. And coming to the cervical spine, the absence of a neurological deficit does not exclude the injury to the cervical spine. So we need to get a radiographic series and a CT scan to exclude the cervical spine. And unless proven otherwise, you should be very careful with the cervical spine, and motion should be restricted. We have a Canadian C-spine rule and an NEXUS criteria. For an NEXUS, we have a mnemonic NSIDE. It is easy to remember, in which NSIDE, N stands for neurological deficits, S stands for spinal tenderness, A stands for altered mental status, intoxication, and any distracting injuries. And Canadian C-spine rule, it usually tells who are the patients who need an immediate radiological assessment. So any high-risk factors like age more than 65 or a dangerous mechanism of injury, which tells about the fall from height of more than 3 feet, and bicycle collision and a motorcycle recreational vehicles. These have a high-risk factors and you should get a radiographic done. If the person is not fitting into this, we need to go for a low risk. That is a simple patient who is sitting in an emergency department, an ambulatory patient, and delayed onset of neck pain, and an absence of midline cervical stabilization. If it is a no, then you need to get a radiological diagnosis. And if he is able to rotate his neck by 45 degrees, you can wait for your radiography. And coming to neck, it needs a proper inspection, palpation, and auscultation. We need to auscultate for carotids to see for any bruits, and the major cervical injuries or vascular injuries of cervical region are because of the penetrating or blunt forces. A blunt carotid injury can lead to coma, and usually we have a seat belt injury over the neck, and the neck injuries usually can be hyperflexion because of the hyperextension or hyperflexion. So you need to get a CT angio of the neck and the neck vessels to rule out any neck injuries if there is a suspected injury to the neck. And you can see in this image, there is a large hematoma being seen at the carotid level. So penetrating wounds that extend through the platysma should not be explored manually or probed with instruments. You need a surgical consultation for any injuries to the neck which are penetrating, as there are high chances of them having a vascular injury as well. The finding of active arterial bleeding and expanding hematoma with arterial bruit requires operative evaluation immediately. And this sort of hematomas are likely to compromise your airway within a very short time. So you need to be careful in protecting your airway as well. And coming to the chest, visual evaluation of both anterior and posterior part of chest is needed, especially to rule out any pneumothorax or a flail segment. You need to palpate the entire chest cage, including the clavicles, ribs, and the sternum. Sternal pressure can be painful if the sternum is fractured or a costochondral separations are existing. What do you need to look for in a chest trauma is the sternal fractures, the rib fractures, the flail segment, and the cardiac tamponade, which you have a decreased heart sound. And we have a Beck's triad, in which whenever you're suspecting a cardiac tamponade, you will have a triad of hypotension, distended neck veins with a muffled heart sound. And the most devastating is your aortic rupture or a dissection. In this, you will have a mediastinal widening. You can see in the image 1, if there is a widened mediastinum than normal, you can suspect an aortic rupture or a dissection. And coming to the abdomen, abdomen can be a major source of bleeding. So your normal initial abdominal examination does not exclude a significant intra-abdominal injury. Pelvic fracture should be suspected by ecchymosis over the iliac vessels, pubis, labia, or the scrotum. Pain on palpation of the pelvic ring is an important finding in an alert patient. In addition, assessment of the peripheral pulses is very important. This helps us in finding any vascular injuries. And a patient with unexplained hypotension, a neurological injury, or impaired sensorium secondary to alcohol or any other drugs have an equivocal injury of an abdomen as well. So these should be considered either candidates for an abdominal ultrasound or a diagnostic peritoneal lavage. And if your patient is hemodynamically stable, you can go for a CT abdomen. So usually our pan CTs, which we do in an emergency, helps to rule out many of the head injuries, chest and abdominal injuries. Coming to the perineum, rectum and the vagina, the perineum should be examined for contusions, hematomas, lacerations and the urethral bleeding. A rectal examination should be performed to assess for the presence of any blood or to assess the integrity of rectal wall and the sphincter tone. So whenever a patient is having a warm peripheries with loss of rectal tone and priapism, there is a high chances that the patient is having a spinal cord injury. And the vaginal examination should be performed in patients who are at risk of a vaginal injury, the walls and the lacerations to be documented. In addition, the pregnancy test should be performed on all females of a childbearing age. And most important is the extremities, which we usually overlook. The extremities should be inspected for your contusions and the deformities. The palpation of the bones and examination of tenderness is needed. A ligament rupture produces joint instability, and impaired sensation and loss of voluntary muscle contraction or strength usually refers to a nerve injury or ischemia. So you should be careful in ruling out a compartment syndrome as well. And a musculoskeletal examination is not complete without examining a patient's back. And coming to the what are the adjuvants of secondary survey, as we have already discussed the primary survey adjuvant. In secondary survey adjuvants, we have a X-ray examination of spine and extremities. The CT scans usually come under the secondary survey. The CT scan of abdomen, chest and spine, and the contrast urography, your angiography, your bronchoscopic and other esophagoscopic procedures, these are all after the secondary survey. And the tertiary survey is done in our ICU usually to prevent any sort of missing injuries. So you need to reevaluate from head to toe, and this should be done within the 24 hours of admission. There are studies which show that 89% of the blunt injuries are missed out and came to be seen in the tertiary survey. And coming to the diagnostic peritoneal lavage, this is a procedure which we are not doing it recently because we have a ultrasound bedside, which is a much more better marker than the diagnostic peritoneal lavage. It is a surgical diagnostic procedure to determine if there is a free floating fluid. So how we do is below the umbilicus, we give a local infiltration. We dissect the planes till the abdominal cavity and you aspirate and see if there is any blood coming out. If there is nothing coming out, you need to give a bolus of fluid into the abdomen, wait for 5 minutes and re-aspirate and see. So if you're when we consider your diagnostic peritoneal lavage to be positive or you need an operative exploration is more than 10 cc of blood in your first aspirate or more than 1 lakh of RBC or 500 of WBC, the presence of bile, bacteria or food particles and your amylase levels more than 75 and your bilirubin is more than 0.01. with an ALP of more than 2 in the DPL fluid, this is considered to be a positive test. And coming off to the role of ultrasound in trauma, using of ultrasound in trauma has been very much beneficial to assess for the hemoperitoneum and hemopericardium. So we need to EFAST. There are 5 components where you keep an ultrasound probe. The first one is a subxiphoid to see for the pericardial, to see for the cardiac tamponades or a pericardial effusion. The right upper quadrant, that is a Morrison's pouch or the right costophrenic angle. The left upper quadrant or the splenorenal axis to see for the left costophrenic angle. The pelvis and the bladder, and the lung, the apical midclavicular or the wherever your injury is suspected. So these are the probe positions, and some of the, in the first image you can see a cardiac tamponade, and in the second one you can see a collection around the liver. So these are the different probe positions which we usually do. And coming to the what are the trauma guidelines which we follow day to day is, previously we used to follow the NICE guidelines of trauma, which was in around 2016. The European guidelines for management of major bleeding and coagulopathy, the Eastern Association of Surgery for the Surgery of Trauma guidelines, the WHO guidelines, and the ATLS guidelines. Nowadays, we are mostly going out with the ATLS guidelines, which is reviewed every 5 years, and we are expecting the new guidelines to be coming out this year. And what are the latest updates from the 9th edition to 10th edition? I'm not going through every aspect, but only the major findings related to this topic will be reviewed here, as the rest will be discussed in the later topics. And in the initial assessment, we need to give a 1 liter of fluid, which is a judicious approach. Focus on your massive blood transfusion protocols and use of IV tranexamic acid. Be aware of the coagulopathy, and the Canadian C-spine rule is added out, and the trauma team. We need to have a trauma team to make the things happen in an order. And coming to the initial assessment of fluid bolus, a bolus of isotonic fluids of 1 liter for adults and 20 ml per kg for pediatric of less than 40 kgs should be judicially given. And aggressive resuscitation before control is increasing mortality and morbidity. If a patient is unresponsive to your crystalloids, you start on your blood transfusion. And coming to the airway and ventilation, the changes are the rapid sequence intubation, change it to drug-assisted intubation, and the use of video laryngoscopy, which needs to be, you need to have some experience on using a video laryngoscopy, that too in emergencies, and the trauma team for a proper assessment of the airway and coordinating things to happen better. And the shock, the classification of shock or hemorrhage has been changed. They have amended basics into the classification. So this is a very important change which we had from previous one. And in this we have the early use of blood and blood products, tranexamic acid. So coming to the ATLS of hemorrhage classification, we added a base deficit into the classification. As we know all the other classifications like class 1, class 2, and class 3, class 4. The base deficit of 0 to -2 is class 1, -2 to -6 is class 2, -6 to -10 of base excess comes under class 3, whereas more than -10 comes under the class 4, which is a severe sort of hemorrhage. And early blood and blood products, resuscitation with blood and blood products must be considered in patients with class 3 and class 4 of injuries. And early administration with a low ratio of blood cells to plasma and platelets can prevent the development of coagulopathy and the thrombocytopenia. Hello.
You have lost your screen, Hari.
Sir, from where did I lose?
From blood products.
1 minute.
From blood and blood products, we lost the presentation.
Okay. Sorry for the inconvenience. And whenever a patient is having stage 3 and stage 4 of a classification of hemorrhage, you need to start on early resuscitation with blood and blood products with a low ratio of packed RBC to the plasma and the platelets to prevent the development of coagulopathy and thrombocytopenia. And the management of coagulopathy, uncontrolled blood loss can occur in patients who are taking antiplatelets and anticoagulant medications. So you should have an initial sample if you're available of the monitors like thromboelastogram or ROTEM. This should be considered. This helps in assessing the coagulation deficit of a patient. And consider administering the platelet transfusion even with normal platelet count when your deficit of your platelet function. So this we can know through the TEG or a ROTEM. And role of tranexamic acid, yes, as per the European and American military studies, they demonstrate improved survival when Tranexa is administered over 10 minutes within the 3 hours of injury. And when bolused in fluid, follow-up infusion of 1 gram over 8 hours in the hospital is needed. Thank you.
It's been an exhaustive but very crisp and informative presentation. This will be the template for the next few sessions. But few things we should always remember that trauma is a very complex situation. It is usually a normal physiology that has gone wrong because of an unfortunate incident. So these patients are usually well preserved hemodynamically or from a cardiovascular respiratory point of view. So the derangements are all acute. So you need to intervene quickly and efficiently to reverse this result. The other thing we need to remember is that trauma is a systemic inflammatory response state, and some of the manifestations of sepsis are also seen in trauma. One of the interesting aspects of trauma, especially in young patients, is the augmented immune clearance. So these patients usually have high GFR, so we need to factor that in when we are triaging these patients. The availability of ultrasound has actually made the role of BPL very less, and in most centers it's been given up in favor of fast scan and then possibly a CT. So that's another aspect of trauma. As Harini said, using video laryngoscope, but one of the dictums of trauma is that do not use a new gadget or procedure or maneuver which you have never used before for the first time when you are seeing a severe trauma patient. Use a method, use a tool, and use a gadget with which you are most comfortable, because time is everything in trauma. So next week we will look at chest and abdominal trauma that will be dealt with by Dr. Shiva, guided by Dr. Kishore. Till then, take care.